All right. Good afternoon, everyone. My name's Danny. I'm the program coordinator for the Office of Cancer Research and Cancer Training, Research, and Education at Karmanos Cancer Institute. And welcome to our March 31st Health Equity Book Club. This is our the quarterly meeting that we all get together and we talk about books and materials. This quarter, we are talking about a research article, and we are very fortunate to have some of the co-authors of that article on our panel today. I just want to go over some basics while we are getting everyone loaded in. We're doing standard Zoom webinar format. We've got our Q&A on the bottom, so feel free to pop any questions you have as we're rolling along. And Dr. Simon, as our moderator, will answer them and get them to the panelists. Or if you want to send a message directly to me, I think you can do that. If not, I can turn that feature on. If you want, you can also raise your hand. If you have something relevant to say, we are not opposed to bringing people on to answer their questions audibly or verbally, whichever one that is. At the end, you'll get a survey that will come automatically from Zoom as soon as you end the session. So getting more feedback from that would be great because we want to make sure that we're doing a good job and that we can read books that are of interest to our general book club members. So without me going on any further, here is Dr. Simon.
Thank you very much, Danny, and thank you so much for ahead of the event for helping coordinate all aspects of this event. And of course, thank you to Dr. Michele Cote. So good afternoon. It would be nice if I could welcome you to the spring event for the Karmanos Cancer Institute Health Equity Book Club. It's somewhat spring-like, and I do think spring is just around the corner. It's officially spring, so we could call it the spring event. We are now into our third year of reading books, and we're specifically reading books mostly. Today, we're going to read an article, I think the same purpose, and the books address issues of systemic racism and health inequality. Yes, we're all, some of us are busy as healthcare providers. We are keeping up with the rigors of academic life, medical practice, and the nuances of how to best treat our patients. We are also busy as patients navigating treatment choices, the healthcare system, and how to successfully survive cancer and other medical issues. All of us are busy with our personal obligations. Despite this, I still feel that it's important, we are busy, it's important that we at certain times drop everything and read. And maybe this was really drummed in my head when my daughter was in 5th grade and the assignment was 30, 30, 30, read 30 yourself, have somebody read to you 30, which was me, and then read to somebody else for 30 minutes. So despite this, I feel strongly that the books read in this group help us provide a framework in which to both learn from the past and plan for the future. We should not let technology take away our ability to read. Okay, it's okay to read on a Kindle as long as you're reading, or audiobooks are acceptable as well. But what better time than now has it been to read the books we've read so far? Medical Apartheid by Harriet Washington, Caste by Isabel Wilkerson, White Fragility by Robin DiAngelo, The Health Gap by Michael Marmont, and Black Man in a White Coat. And we were so fortunate to have Dr. Damon Tweedy speak about his book at the last book club, and hopefully we'll have additional authors in the future. So today we are discussing our article, A Review of Research on Disparities in the Care of Black and White Patients with Cancer in Detroit. That was written by myself together as co-first author with our third-year fellow, Dr. Sreejata Raychaudhuri, who really did a mammoth amount of work on this, and 9 of our colleagues who I'll introduce. I first thought of the idea of the article early in the pandemic when driving home to Ann Arbor from Detroit, and it was late enough to hear that day's second showing of Detroit Today. And I heard our dean, Dr. Roy Wilson, speak about how COVID had disproportionately affected the Black community, or has. I thought about the years of research on disparities in cancer care and outcomes that have been done by our group. I wondered if we could summarize our past work and frame how we should move forward in the future. I was honored to work with experts covering the areas of epidemiologic research, Kendra Schwartz, Ann Schwartz, Michele Cote, and Jason Booza. We were influenced by others in the Disparities program. There are not co-authors, of course. And behavioral and communications research, Lauren Hamill, who's on the panel, Lou Penner, Felicity Harper, Susan Egley, and Hayley Thompson. Lou and Kendra Schwartz actually came out of retirement to help us with this project. This work could not have been done without the efforts of the entire group. I learned a lot from the project, mostly from my co-authors. Here are a couple of things I learned. I learned that race is a sociopolitical construct that often serves as a proxy for historical and ongoing disadvantage in social, economic, environmental, and structural factors. I learned that race arises from racism and is not rooted in biology. A biological basis for race has been debunked in the scientific literature. I also learned that ethnicity is another sociopolitical construct and not rooted in biology that refers to the social characteristics people may have in common, such as language, religion, regional background, traditions, and culture. Ethnicity is not equivalent to race, and we should not have a race/ethnicity category in our research as a separate descriptor. Lastly, ancestry is a person's country or region of origin, or an individual's lineage of descent. So ancestry and genetic admixture refer to genetic exchange among people from different ancestries and are appropriate terms for genetic analyses, but ancestry is not interchangeable with race or ethnicity. So there could be many Hispanic and non-Hispanic, different ethnicities. People of many races could be described as Hispanic or non-Hispanic. So in this article, we talk about 4 generations of disparities research. The first generation, we use commonly database like our Michigan Department of Community, MDCSS, or SEER data to identify and document the existence of health disparities. Second generation research is more analytic, and it's an attempt to look at what factors could possibly explain these disparities. So in our analytic research, it's very common, and I've done this, to try to account for socioeconomic differences as a potential factor explaining racial differences. Now, quoting from our article, and it's explained to me by Dr. Penner, Dr. Susan Egley, and others, while controlling for SES is an accepted practice in studies of treatment disparities, 2 important caveats should be taken into consideration. First of all, socioeconomic disparities can be easily traced to legacies of institutional and structural racism, and therefore controlling for SES is an attempt to control for one of the consequences of racism, which remains unresolved. Secondly, in the process of controlling for SES, we create, in a sense, a world where Black and white people kind of overall, I know there's people of all races in different SES groups, but overall, we're creating a world where SES is the same, and this does not really reflect reality. So we write about this in the article. So 4 generations. Third generation research has to do with testing interventions that could serve as solutions to mitigate disparate outcomes. And I know Lauren will speak to that, and Jen may as well. At the end of the article, Dr. Hayley Thompson did a really excellent summary of 4th generation research. And this is where we hope to take the field in the future. So quoting again, we are now laying the foundation for fourth generation research, which is rooted in justice and action to eliminate disparities. In this context, the voice of the community members is an absolute necessity. And I think we've built that structure at Karmanos. Fourth generation research is deeply rooted in community and the racialized context of the populations who reside within them. So I hope that we will hear from all voices and perspectives today. So that's my summary of the article, a little easier than summarizing a 300-page book. So I got off easy this time. And I'm going to introduce our panelists, and we're a little bit ahead of schedule, which is good. So the first panel member is Dr. Jen Beebe-Dimmer. As Jen recounted when we met just before the meeting, we've known each other for many years. She's the program leader for the Population Studies and Disparities Research Program, PSDR, we like to call it, at Karmanos. She is professor in the Department of Oncology at Wayne State University, and she is as well director of the Epidemiology Research Core at Karmanos. Jen is trained in cancer epidemiology. She has a master's and Ph.D. in public health from the University of Michigan. She's been conducting research in the area of health disparities and prostate cancer since before joining Karmanos. She has specific expertise in epidemiology of cancer and predictors of survival after diagnosis. Among her many accomplishments and funded grants, she is the co-principal investigator on the Detroit Research on Cancer Survivorship Grant, Detroit Rocks, which I know she will mention. So Jen, the floor is yours.
Thank you, Michael, for that kind invitation. And I thought my assignment was mostly to talk about Detroit Rocks. I hope that's okay. I'll spend most of my time talking about this landmark study. I'm just going to share my screen real quick. So again, I'm grateful for the opportunity to come talk. And again, charged with talking about the Detroit Rocks, or Research on Cancer Survivorship Cohort Study. This is a study that really began in about 2013, although a lot of the research that's come out of the Population Studies and Disparities Research Program really laid the framework, which allowed us to get funding for this study in the first place. So Detroit Rocks. Detroit Rocks is one of the largest prospective cohorts conducted exclusively in the African-American population. And this study was actually a UO1, funded under a UO1 mechanism. So the mechanism itself doesn't support the science coming out of the cohort. It basically builds the infrastructure that allows researchers, both internal and external, to Karmanos Cancer Institute to conduct important research projects. And I will talk about some of the projects that have come out of this. It really runs the gamut from looking at socio-ecological predictors of cancer survivorship outcomes to most of my research is focused on molecular epidemiology. So we look at germline genetic variants present in this population that predict outcomes. You can see here the overarching goal is to really look at multiplex causes of poor outcomes in this population. And there are several sort of domains of influence that can affect both short-term and long-term outcomes. Mentioned just a few here. If we think about the different domains, there are obviously individual level influences that can affect outcomes in this population. If we look at stage of diagnosis, things like comorbid conditions and other things related to someone's medical history. We also must consider interpersonal level influences, looking at things like social isolation and medical mistrust, which can affect sort of the interaction that survivors have with their physicians. and a sort of higher community level influences, things like community level biases, residential segregation, and neighborhood built environment characteristics. We also have and plan to look at factors which mediate some of these domains with long-term and short-term outcomes. We think about health behaviors. We think about, again, looking at comorbid conditions and how this affects everything from health-related quality of life to longer-term outcomes like mortality, both disease-specific and non-specific mortality. Obviously, access to healthcare is a huge issue. And then the study was funded in 2017, and we have just received a renewal to continue follow-up of these survivors. But as you can imagine, some of the longer-term outcomes will take maybe even decades to look at adequately. So the first 5 years of this study has really focused on some of those shorter term outcomes in the population. So a lot of what we've published to date has been looking at predictors of health-related quality of life, anxiety, and depression. But obviously, in the future, we'll be looking at development of second primary cancers is particularly of an interest to me. We'll also look at disease recurrence and mortality. So the study aims, the aims were to enroll 5,000 African-American cancer survivors as well as a subset of their caregivers. These cancer survivors were all identified through the Detroit surveillance system, cancer registry. This registry has been around since about 1973. So we've got over 1 million cancer survivors in this registry database. The eligible survivors for this biologically confirmed cancer, we first focused on female breast, prostate, colorectal, and lung. We focused on these cancers, health disparities, but these are also happen to be about 2 years after we with collect baseline survey information. I'll talk a little bit about some of the factors that we collect. We also attempt to collect blood or saliva for genetic studies, consent for tumor tissue for both somatic studies as well as also studies that correlate germline genetic variation to the tumor somatic profile. We attempt to collect medical records and we consent for contact for future studies. There's also annual follow-up attempted for, well, it'll be now up to 9 years, but at the time, the first cycle of the study was, it was up to 4 years. So we send additional surveys sort of annually, depending on their baseline examination to basically update the information from baseline survey. So our current enrollment, the competitive renewal was basically funded for longer term follow-up of everybody enrolled in the first 5 years. So we did complete interviews on over 5,000 survivors. You can see the breakdown by method of completion. The study started with options for self-administered online survey or an online survey that was conducted by a trained interviewer. We did
Danny, can you hear me?
I can hear you. It seems like
Yes,
Dr.
yeah.
Dimmer dropped off there.
Right. So I think what we should do, we should be flexible as they are on the radio. And sometimes the people that are being interviewed on radio do drop off for various reasons. And Dr. Dimmer is out of state. So if we can all just remember what she was talking about in terms of Detroit Rocks. And again, I think a lot of what we wrote about in the review article influenced the creation of the Detroit Rocks cohort and grant. So I'm going to introduce Dr. Hamel, and we will likely have time to maybe let Dr. Dimmer come back in once she gets back on the system. Thank you for staying on with us. Okay, so Dr. Hamel, Lauren Hamill, is co-program leader in the Population Studies Disparities Research Program at Karmanos. She's an associate professor in the Department of Oncology. She's an expert in patient-physician communication, cancer treatment disparities, and in building and testing interventions to improve patient-physician communication. She was PI of 2 recently completed NIH-funded studies assessing nonverbal synchrony and nonverbal communication that occurs between Black patients with cancer and their oncologists during clinical interactions. She is currently investigating aspects of nonverbal communication as potential markers of racial attitudes, such as physician unconscious bias and patient suspicion of medical care as predictors of interaction outcomes. And she'll be speaking about her work, perhaps something about the article and where she'd like to see us go in the future. So Lauren, please take the Zoom screen.
Yeah, hi everybody. Thank you for having me tonight. Thank you for inviting me. I think one of the things that I really appreciated about the article and Michael's vision for it was that it included, all of the work that we've been doing focus on communication disparities and how to address those. So I thought tonight maybe I would take a few minutes to go over the intervention that I've been working and testing. And many of you on this call have helped me in one way or the other. And that is the DISCO app, which is the Discussions of Cost app. And what it does is address the issue of financial toxicity or the financial burden related to treatment costs. So I'm going to share my screen because it's now year 3 and I should be able to do this. All right. So I'm going to start here with this slide. Research has shown that 30 to 50% of patients with cancer experience financial toxicity. Now that's across all types of cancer and all patient groups, but importantly, financial toxicity affects certain patient groups more than others. So patient groups that are more at risk for financial toxicity include patients who identify as Black or African American, patients who are younger, and that the younger group is people under the age of 65, so that's an insurance issue. And then also people with lower incomes are more likely to feel the effects of the financial consequences of cancer. And these financial consequences can take a number of forms, right? There can be certainly like the direct out-of-pocket costs for like co-payments or insurance premiums or deductibles. But there's also things like transportation or having to get someone to take care of your family members, like your children or your parents. And this can result in some pretty significant financial consequences like debt. You could potentially face bankruptcy and a number of other financial issues, but those are also associated with psychological problems, psychological distress, even like catastrophic levels of distress over the cost of treatment. We also see that cost influences treatment and patient outcome. So cancer treatment costs can influence the recommendations that are made by physicians and also the decisions that are made between physicians and patients. We also see that the material and psychological aspects of financial toxicity may also negatively influence adherence to treatment and could be a mortality risk factor. So those extreme experiences of financial toxicity could actually hasten mortality due to cancer. And we also see that about 20% of patients will deviate from their recommended treatment because of costs. Other work has shown the influence of treatment costs on outcomes. One study showed that 45% of patients were not adherent to their prescribed treatment. We anticipate that adherence may be even more problematic with oral targeted therapies. So therapies that patients are kind of on their own to administer rather than going into a clinic to receive treatment. And it isn't just an insurance problem. We see that insurance, whether it's public or private, does not protect against financial toxicity. And even though income does offer some protection, it isn't necessarily a foolproof problem solver. So lots of solutions are needed for this, right? Our healthcare system is disjointed, to say the least, disorganized in some cases. And so we're going to need a lot of things to help fix this. And so unsurprisingly, as someone who studies a lot of communication, I look at solutions that could occur at the patient provider level. And this is what's kind of stemmed, my focus in this is that we find that both patients and physicians want to discuss cost. They know, they both want to, but we see from work that we've done at Karmanos that these discussions do not routinely occur. In fact, fewer than 45% of treatment discussions that we've observed discuss cost. And we see in other research that physician engagement around treatment costs is identified as an unmet patient need. So patients want to have these discussions, physicians want to have these discussions, they're not happening, and patients are feeling it. The reason why we want to prompt these kinds of discussions is that it allows patients to voice their concerns. It allows them to improve their understanding of what treatment might be like for them. It allows an opportunity for providers and clinicians to talk about different costs that are associated to treatment, and then ultimately connect patients to resources if they're needed. It can also help inform treatment decisions and plans if there are things that can be done to adapt. And it also helps identify patients who might need some extra help. So certainly there is information gained, knowledge gained, which is important. But if there are patients that are particularly struggling or at risk for financial toxicity or at risk of maybe discontinuing treatment because of that, these kinds of conversations could help identify those patients. So as a part of this work, my team and I developed our Discussions of Cost app, or the DISCO app, which I thought maybe I could take tonight to do a little demonstration of. It's a two-part application. There's a short video, and that's followed by a tailored communication intervention called a question prompt list. So I'm going to start the video. It features me, not because I'm an egomaniac, but because I work for free for myself. So I didn't have the funds to pay professional actors. So me and two of my really close collaborators and friends are also featured in it. So that takes about 3 minutes. So I thought we could do that. And then I'll show the second part of it. And then I can maybe respond to any questions people have. Probably a lot going through your mind about what cancer treatment will mean for you and your family. One thing you might be thinking about is the cost of treatment, such as co-pays, insurance costs, and transportation. We've learned through research and experience that it is important to be proactive about treatment-related costs, even if they seem less important now. In this short video, we will go over the types of costs you may have during treatment and give you suggestions for ways to address those costs. The best way, but one that patients don't often consider, is to talk with your doctor. After the video, you will be asked to complete a short survey with questions about yourself. Based on your responses, you will receive a list of cost-related questions specific to your situation that you may consider asking your doctor.
As you start treatment, you may have costs in a few areas. These include insurance. In addition to the premiums you're already paying, you may need to buy supplemental insurance to cover any gaps in your coverage or pay for your deductible. Appointments and treatments. This could include co-pays for clinic visits, lab work, treatments, or other specialty appointments. Transportation and parking. You may need to travel to the cancer center frequently for treatment, tests, clinic visits, and other aspects of your care. This will require expenses such as gas, parking, or possibly having someone else bring you to your treatment appointments. Working during treatment. Some patients can work throughout treatment, while others may not feel well enough to. If you need to take some time off for either treatment or recovery, this may affect your income. Family and living responsibilities. Many patients have family responsibilities, including taking care of children or other family members. While undergoing cancer treatment, you may need to take care of your children, spouse, or other family members.
Here are a few ways to start managing treatment costs. Starting a discussion about treatment costs with your doctor is a good place to start, especially if there are a few equally good options for your treatment, but they have different costs associated with them. Knowing more about the cost of your treatment may help you and your doctor decide on the best treatment. When doctors understand your financial concerns, they can then refer you to a social worker or a financial navigator. As a team, your healthcare providers can help you determine what treatment costs will likely affect you and how to start to manage those costs. Your healthcare team may be able to help connect you with resources and programs should you need them.
Many people are unaware of what their insurance covers when it comes to cancer care. Contacting insurance companies directly can help you understand what your insurance covers and whether you may need supplemental coverage. There may also be opportunities for you to change your insurance coverage, which may make your care more affordable. Sometimes pharmaceutical companies offer help for patients who need help with paying for their treatments. Your healthcare team can help you decide if this is something you should look into.
The best way to start managing your treatment-related expenses is by starting a discussion with your doctor. Following this video is a short survey that you can complete. Based on your responses, you will receive a list of cost-related questions specific to your situation. These questions can help you start a discussion about costs with your doctor. So patients will see that first, and then that's followed by this here, which is a tailored question prompt list. So the idea for the intervention was, let's educate patients on some cost-related issues they might incur. Here's some ideas to start managing them, and then finish by saying, you know what, you can have these conversations with your physician. So then this leads into a really brief survey. You're seeing it demoed here, asking some really basic questions about the the patient's circumstances, what their family and friends situation is like, what their insurance situation is, what their transportation is like. Do they have their own means of transportation? Is it reliable? How far away do they live from the cancer center? If they're employed, and then if they feel comfortable responding questions about their annual household income and kind of their ability to pay through the bills that they currently have. And then also if they anticipate having to make some changes due to the cancer diagnosis and the treatment that they're likely to start receiving. And once they go through this, what the app does is take the information the patient gives them and then populates a tailored list of questions specifically for that patient. So here would be a list of questions based on the data that were inputted into the survey. And then the patient can then use that. They can take that into an interaction with their physician. They can use it in subsequent interactions. But the point is like what we want to do is develop an intervention that patients can give them some information, can give them some action items, and help connect them with the services and information that they need. So right now, my team and I are in the middle of testing this in a large-scale randomized controlled trial with physicians and patients at Karmanos. And of course, we're testing this with patients who are both Black and white, patients who are older and younger, and patients from different income levels. So we can see if it gives added benefits to the patients that are more likely to experience financial toxicity related to cancer treatment. So that's kind of a brief overview. I'm happy to discuss. I cut Jen off, so if she comes back in, certainly happy to let her bounce in.
Okay, well, great. Thank you, Lauren. I think we are on time, and we're going to have, we have about 35 minutes at the end to have a general discussion. So certainly questions focused at your work can come in at that point. And Danny, any word of whether Jen's coming back in at this point?
Not that I see yet, but I've got my eyes open.
Okay, great. So we'll be alert to that. And I think we should just move along with the rest of our panel. So I'm going to introduce Natalie Snyder. In all these book panels, we try to have a trainee. We have a community member. And actually, I think I put the most important towards the end. Certainly it's very important to hear about the research that we're doing or hear discussion of the actual book. But moving into the future, we feel it's really important to hear about trainees and as well from our community activists, if we are really doing the type of research that will be accepted by the community. So Natalie Snyder is our next panel member. She is a second-year cancer biology PhD student at Wayne State University School of Medicine. Her current research focuses on cancer epidemiology and the racial disparities of aggressive subtypes of colorectal cancer among African Americans. Her work combines both the socioeconomic and genetic factors that disproportionately affect African Americans with cancer to better understand how to treat and prevent cancer in this population. So Natalie, this is your turn.
Great. Thank you so much, Dr. Simon, and thank you for the invitation. This really means a lot to be able to talk about, my experience as a young investigator or trainee, I suppose. So I don't have slides, but I will be talking about, the things that interest me from this paper, why I chose disparity research as a subject area in graduate school, and how I think disparities research is going to guide my career after grad school. So starting with the paper, I think it's a really good reminder of the issues at hand and what we've looked at so far, a bit of a history lesson. It's no surprise that I'm pretty young. I'm only 23, so a lot of these studies are actually older than I am, not to age anybody, but I think it's important because I wasn't aware of these issues at all until I was about 21. And I think that, to just briefly touch on the education system, I was raised in Southeast Michigan. I wasn't aware of any sort of racial disparities in any capacity until late in my undergraduate career during my degree. So as Dr. Simon mentioned, my research is mainly in colorectal cancer. So I think it's good to be reminded that disparities don't just exist in the cancer site that I research, and that there are issues, though they might present themselves in different ways at different cancer sites, that there are issues at hand that we are still working to solve. I think papers like this need a lot more exposure to people at all levels, not just academic, but I think that, my experience, I am better to talk about, exposing these at academic levels. Those might, require liaisons who might be able to translate the work from a formal science jargon to more approachable and digestible text to people in different areas. I think that exposing these sort of issues to people in any sort of discipline is the reason that we can have a larger effect in changing outcomes. Disparities in my program has become a pretty big interest in the past year and a half since I've been here, and I'm sure it has been bigger since I've started. But I feel that it's only growing as time's gone on, and that getting researchers who are in basic science research involved in racial disparities, I think is going to be able to really translate these macro effects to the molecular cellular level, and how we can create treatments that might affect people who are disproportionately affected by cancer at a different genetic level. I think I really appreciate the way this paper, kind of talked about the so what, and how we can solve these issues. I think, in my opinion, epidemiology, so I'm a training in molecular epidemiology, but epidemiology as a whole, I think, finds problems in at the population level, and we see issues that we can report to other scientists, but a lot of people will kind of think, well, so what? This is an issue, right? But can we actually fix these? And since these issues are, incredibly daunting, and we see that they're coming from a lot of these systemic policies that might have been put in place decades and decades ago. I think this paper really showed that, simple interventions, just like the question prompt list that we talked about, can be really well received and actually really effective. I think also touching on the uncomfortability or the touchiness that reading these papers can cause is really important for all of us to realize that, these issues affecting people, or these issues are, affecting people in your own area. They're not, across the world in a whole other country. These people are right here. They're, across or within the city that you live in, and being aware of, the issues that people are facing helps us understand, what people are going through and how we can actually make a difference. And of course, understanding the privilege that I have to be able to research these sort of things and not actually be affected by them, I think is really powerful. I also really appreciated the implementation of the Cancer Action Councils to actually help people who are affected. The answers to these problems aren't solely found in the office of somebody who's just running statistics on cancer survivors, but actually using community outreach and discussing the problems with patients to have them tell us what they really need and what will actually be effective at solving some of the issues that they might be facing. And I think that KCI overall has done a really good job with this. During our first year of our program, you do a clinical rotation. So I rotated, I think, in 4 different clinics. And I found in different instances where just social workers were able to have really good relationships with the patients, whether they were finding transportation to their appointments, especially if they had radiotherapy and they were coming to the clinic every single day. or just being able to provide accurate information on treatment plans and medication. Some physicians would, print out sort of cheat sheets to the medications that they were taking, and just making it very accessible so that the patient doesn't have to be a doctor themselves to sort of understand what is going on. Next, I want to talk about disparities research and why I chose it as a subject area. So again, I kind of touched how my program is heavily basic sciences focused. Our biggest department is molecular therapeutics, and that's followed by tumor biology, microenvironment. So as a whole, we're really focused on the molecular mechanisms of cancer and researching treatments that'll best, counter these mechanisms of tumor progression. And PSDR is a bit of a smaller group in regards to the cancer biology graduate program. Before grad school, I spent my undergraduate degree here at Wayne State as well. I worked in a lung cancer research lab in molecular therapeutics with Dr. Steve Patrick. And it was him and the grad students in that lab that made me want to go to grad school and made me choose cancer biology, and specifically the program here at Wayne State, against some of the other offers I had at different universities and different programs. But I want to touch a little bit on my undergraduate experience here. So my degree is actually in nutrition and food science, which I think is sometimes people are a little bit surprised of with my trajectory. But it is a pretty biochemistry based degree. So we learn obviously about metabolism, digestion, and food chemistry. But during my degree, I got my first taste of the issues of social determinants of health. There was this class titled The Controversial Issues in Nutrition and Food Science, taught by Dr. Diane Kress. And though I don't think the issues in here were controversial, they can still be touchy, like the rates of poverty and hunger among African Americans, especially among Detroit, and as well as the issues of food deserts and food swamps and the overall lack of resources that people in underserved populations might have, which includes just access to grocery stores and healthy food, which of course is really important in overall health. Go back to sort of my experience in grad school. When I joined, I had a lot of experience in molecular therapeutics. So I was interested in branching out and broadening my skill set as a researcher for post-grad, which won't be for a while, but still, nonetheless, these are skills that I want to sort of hone in on. And this is when I was introduced to population sciences and disparities research in this sort of area of work. And I found that I had a really a big interest in the understanding of a macro view of patients and how the molecular mechanisms, the cellular mechanisms may affect patient outcomes, and how your environment, which can be dictated by these social determinants, how these all sort of play together, and how that different people will experience disease differently, including cancer. And I think that as I've learned more about disparities, and for a lot of my classmates as well, it's kind of shocking. I would sort of think to myself, how is this still an issue in this current day? As I've grown up, I've sort of surprised that people are still affected by these, and shocked that we haven't really done anything about it. And especially in basic sciences, I think that there is a need to focus on the disease mechanisms in those who are most affected by the disease. So we know that African Americans are, just to take colorectal cancer as an example, African Americans are more affected by colorectal cancer. Are we using African American patient samples in the experiments that we're running? Are we focusing on the sort of molecular differences that might be affecting the way these patients are treated? Are we focusing on the people who are the most affected by this disease? And I think that that's been an issue that my program has been addressing lately. And I think that people are really interested in that. And I think just thinking about these issues broadly, it really brings you back to the bigger picture, what really motivates me when grad school gets really tough. I feel like my work is still really impactful. And I feel like the work that I'm doing right now is really important, rather than maybe just getting my head stuck in a plate of cells and looking at things every day. I think I can take a step back and think that, my work is really important, and that I think everybody's work is important, but for me, I think that it's really motivating. And I also feel that my classmates feel like this too. The current generation of students, graduate and undergraduate, I think are really susceptible and interested in this work. So I think it's really important. And I'm really, really honored to be on this panel today to be talking about the student experience and disparities. There was a recent elective course taught by our program focused on cancer disparities in fall 2020, and that was taught by Dr. Hamel. And I took this course as a first year, and I found that my classmates were really engaged in this work. And again, a lot of us are really shocked to see some of the statistics of the way that different populations are affected by this disease, because again, we weren't really aware of these and how present these issues are, and how the systemic and structural issues which were implemented decades and decades ago are still affecting African Americans and other minority populations in just health disparities. I also really like that this work is highly collaborative, and I don't think you need to be an expert in molecular epidemiology to be able to ask questions and raise suggestions. Again, I think it's something that's really interesting to my classmates, and I feel like when I present work specifically, I've had so much more discussion lately. And I think being able to bring up these issues in a way that's digestible to any sort of person, I feel like we all, in our human interactions, I think that we are really able to collaborate because these are obviously important issues. Also, I don't think that you need to be an expert in the field to raise suggestions, which I think is really exciting because we are getting more interest from those in basic sciences who want to be involved with this, and they realize that this is important work in their area of expertise. And I guess lastly, I hope I'm not talking everybody's ear off and babbling away, but just to talk about how I think disparities is going to guide my career. I do see myself working hopefully in government and be some sort of health policy to be able to kind of talk between scientists and policymakers, to be able to get that, again, that translation of science and also getting into community outreach to really just bridge the gap between the scientists and policymakers to get the information to the people who are going to be able to make the biggest impact and the people who are affected by these diseases. I'm also really interested in genetics and genetic research, in cancer incidence and mortality, possibly involving better screening and genetic testing for race-specific issues, or not race-specific issues, but in the areas where populations where people are affected by different genetic mutations, and being able to provide a better personalized medicine approach. I think that disparities research, besides cancer, making medical devices tailored to those they might work best on. I think early in cancer, or in COVID, we were talking about the issue of pulse oximeters not working very well on people who were not of fair skin. And that just making medical devices actually work on people, not just one set of people. And yeah, I just think that disparities work overall is going to become even more prevalent as my career progresses. I hope that wasn't too much. That's just kind of my personal experience.
Perfect. That's really motivating, and it's really nice for us to know that there are students like you, and that you speak about your colleagues, and there's really hope for the future. So I'm going to introduce a final panelist, and then all the panelists will get a chance to talk more and either interact with each other and or answer questions in the chat room. So our last panelist, Leslie Wilson-Smith, is going into her 4th year as a breast cancer survivor who believes in living life with a purpose. Starting her breast cancer journey in January of 2019, she knows the beauty of life and all the wonderful things it brings. Leslie believes that her success in beating cancer is attributed to early diagnosis and working with an amazing cancer team. She views every day as a second opportunity to live life to the fullest and enjoy it with those that you love. Leslie is committed to working as an ambassador with the Making Strides Against Breast Cancer Detroit team to raise funds to find a cure for the cause and to stop cancer in its tracks. Additionally, as a breast cancer survivor, Ms. Wilson-Smith has committed herself to cancer research, where she lends her voice and opinion to several organizations. So it's really my pleasure to have Leslie join us as our 4th panel member.
Good afternoon, Dr. Simon, and the rest of the wonderful panelists. And our listening audience. I want to thank you for allowing me to be a panelist on this book club review panel. When I read the article, it resonated with me so much because I have my dad and an uncle who have made their transition due to prostate cancer. I have two uncles who have succumbed to colorectal cancer. My mom and her baby brother succumbed to lung cancer. Then I have an aunt and myself who, well, my aunt succumbed to breast cancer, and now I'm a survivor who's in that journey. Let me tell you a little bit about me. I am a college-educated, professional, working, 59-year-old African-American woman. I say that because, as you can see with the disparities, I fall in that group of population that may be affected the most by the disparities when it comes to cancer treatment research. I was in what they call the retirement chapter of my life because I was finally able to see what I call the retirement circle. I don't know about anyone else, but I was finally reaching that stage in my life where life was awesome and I was excited about being in the club. Well, in January 2019, the wind in my balloon began to deflate. And when I went for my normal mammogram, and I could not pass the screening. From that normal mammogram, they brought me back a second time to do a follow-up screening. And I was a little bit angry because the second time I just truly believed the people or the technician who was performing the screening didn't know what they were doing. Now, I'm not happy to say that at that time, my biases against the ethnic background of the people performing the screening, I had very little confidence in them. And when I got called back for a third screening, oh boy, I was livid, angry, on top of the ceiling. And I was at the point that I had reserved myself that I'm just not going back because they don't know what they're doing. I don't know why they keep calling me back because I told them to do this and I told them to do that and no one was listening to me. And I'll never forget it. It was one Friday morning about 11 o'clock, I got that telephone call that says, we have to do another screening and you must come back. And I told them I'm not coming back because your team don't know what they're doing. And she says, not only are you coming back, it's a must that you come back. And to come back, I promise you one thing, I'll do the screening myself. What that did for me was to have someone who cared about me, cared about my well-being, because she could have taken the attitude that I had and been negative and said, well, go ahead on. It's not me, it's you. But she wouldn't let that be. And sure enough, true to her word, when I got there, she was waiting on me. And once again, I went in on my rant and I let her have it. And she just said, oh, come on. Very even keel. Let's just go through the screening again and see what they show. And I'm still sitting there fussing and fighting. And she calmly looked at me after she had conducted that third set of screening and said, sweetheart, it is not your right breast that we are concerned about. It is your left breast. And she took a red pen and she drew it on the images. And she said, this is why we keep calling you back. She said, but I have to take it over to the team and let them look at it. And we'll make a decision. Had she not been concerned about me, I would have probably left and been true to my word, not go back for another 6 months or to a year. But what good would that have served me? I would have probably been deceased or dead. But she wouldn't let it go. She was very, very concerned about me. And for that, I'm grateful. From that, I went into biopsies, and the biopsies confirmed that I did have breast cancer. And they paired me up with the team. I must admit, by the time my team was put together, And they wrote a letter and told me that this is the date we want you to come in. And because we need to sit down and tell you what you're basically looking at, we encourage you to bring someone with you, because the information that you're going to receive can be overwhelming. I'm fortunate. I had people that was fighting in line to go with me. So I didn't go alone. So all of the questions that I could not hear, they were there to ask those questions on my behalf, because I told my team, don't hold anything back, get it to us straight. And they were very concerned about the questions that we had to ask. They were not in a hurry to leave that room until they felt the question that we were going to pose was answered. And to imagine you have surgeons, you have radiologists, you have oncologists, you have the nutritionists, you have the anesthesiologists who are willing to sit with you 45 minutes to an hour to answer your questions. That is unheard of. When I went in, they showed a video that sort of prep you for what to expect, what to look forward to, what to eat, and all of those things. I walked out there with, after viewing that video, and saying, you know what, I'm gonna go and get me a second opinion. Person working with me says, no, you're not, because the type of cancer you have is aggressive and angry. Once again, in that journey, I had someone in the medical field who cared. And her thing was, by the time you leave here and you go in search of a second opinion, your cancer could have spread it, and it could be at a stage 4, and we may not be able to do anything for you, because they had explained to me from a stage 0 to a stage 3, they could treat and cure my life, and save my life rather. But at a stage 4, they could just only treat it. 9 times out of 10, that stage is terminal. And she says, you will not leave out of here today and go find you a team tomorrow. You're going to have to take some time to find somebody who will be interested in working with you. Then when they bring you in, they're going to want to do their own testing and screening, and they still may not take your case. And then you'll be right back here with us. And then at the end of the day, she told me, she says, it's your decision, your body. You can do whatever you want to do. But if it was me, I would not do that. I would take the team that is assembled. Best decision that she could have told me, because the team that was assembled to wait on me is, and I say is, and was a world-class team. They never stopped educating me on the process and what to expect, and holding my hand along the way. And not only did they do that, I think I was a little bit better prepared than most, because I'm with a sorority. And there were women within my sorority who had gone through breast cancer. So I perched myself at their feet and say, tell me what your journey was like. Tell me what I'm in for. Tell me what I can suspect. And by knowing some of those things, it was not so much of the fear factor going into my journey, because I figured someone had shared their knowledge of what to do, what not to do, what to expect with me. They had given me hope that they could beat this. After I had my surgery on April the 12th, and I'm coming up on my anniversary, I went into chemo infusions, and I had radiation, and it was all with the wonderful hospital. Everybody have their own. Mine is Henry Ford. That's where my team was assembled out of. I then wanted to know more about whether or not I am a carrier. So that's when I decided to do the BRCA1 and the BRCA2 gene mutation testing. And I was concerned about going that route, because I have she's currently 29-year-old daughter, and I have a sister who's 20 years my junior. But just hearing the story that I told you before about cancer being in the family, I wanted to know whether or not that gene was prevalent, and I was going to pass it on to them. If it was going to be that, then I needed them to prepare and know what to look for and make sure they stayed on top of their screening. Maybe screening for them wouldn't be annually. Maybe it would be every 6 months, because now they're on a watch list. In addition to being a fighter and wanting to stay on top of cancer and knowing what it was and knowing where it is in the family, how could I fight it? I became a participant, because my whole thing was, I'm committing myself to research. The only way we're going to correct some things is to commit to research and not stick our head in the sand, educate ourselves on what's out there and how we can fight. And I had already been hearing how African Americans don't participate in research studies, but we are the ones who need it most. We are the ones who suffer the most because of economic disparities, because the communities in which we live don't have the facilities, because we can't afford it, because we can't get to it, because we're so secretive. Even in our own family lineage, we won't tell people of the disease or the illness that we have. We take them to our grave, and what benefit does that do for us? So I wanted to be a change agent. I wanted to affect how treatment, like Natalie also said about the equipment, the medication that would be administered or used for African Americans will be a little bit more effective. So I committed myself to participating in the ARISE studies, which is an African American resilience in surviving cancer study. That's a 5-year study that's funded by the National Cancer Institute of the National Institute of Health, that aims at identifying targets of change and informing the development of intervention to address causes of poor health-related qualities of life experienced by African Americans. I was very interested in that, and I'm grateful to Dr. Felicity Harper and her associates down at Wayne County Wayne State University, as well as those with the Karmanos Cancer Institute. Because when I participated in that study, you have to be committed. That's one thing that I've learned now, because you're going to get those surveys. You're going to get those surveys with that research. You have to be committed that you answer the questions and you do them timely. Otherwise, why sign up for the research? The one that I signed up for with the fathers and daughters having a correlation, and if the father had prostate cancer, then the daughter could probably have breast cancer. I signed up for that one too, which was also through Wayne State. And I just wanted to know, because I had lost my father to prostate cancer. Third thing I became involved in was the All of Us research program. And that was programmed especially driven by when President Barack Obama was in office. He wanted at least 1 million people to sign up to participate in this study, but he definitely wanted African Americans to sign up so that we could be part of that research and that data. And being a part of a fraternity and other national African American organization, that was one of the things that they pushed. And I definitely supported that. And lastly, I became a cancer ambassador through the partnership with the American Cancer Society, making strides against breast cancer, to the Detroit chapter, where we go and we walk annually. And that's my opportunities to raise funds, because with any research that you do, it has to be financially supported. And so my means of reaching out to my communities and soliciting funds to donate is also important to me. I am concerned at some point when I entered the research, because my question became, what will happen to the research data? Who controls it? Will it be used against me in the future going forward? And I think the good outweigh the bad. and they basically tell you they are not selling this data to third parties. They're simply using it to collect and to better the treatment so that the outcome for those who are suffering from the disease can be a positive one. And so that sort of set my mind at ease, because I didn't want it to be used against me in the form that I wanted a job and someone had my information, or I was trying to get insurance and they was using that against me. So that's the reason. And that was another reason I basically looked for research that basically did the questionnaires and not taking samples, because I didn't want to give up samples. And when I was in the program, I didn't want anything to do as far as going into a trial clinic of research. No, we going in fighting with what I know or I suspect to be proven outcome in medicine that's on the market. I have a brother-in-law now who's fighting blood cancer, but he's been in numerous research projects for the last 6 years. And I know that they are using him as a person to collect data to see what program works, what medicine work, and the outcome.
Leslie,
I do believe.
Leslie, yes. Can I interject for a second?
Yes.
You know, actually, as I see from the chat room, everybody's so impressed by your involvement. I'd like to, you know, I don't want to take away your ability to speak, but that's some of my job as running the panel. I'd like to try to open up to questions and answers, and actually, I'm sure there's going to be some questions directed at you as well. But we had, there's a comment, and I might ask everybody to comment on this, and maybe starting with Lauren. There's a comment from somebody, I think very thoughtful: stop assuming that all African Americans fall into one classification. Realize and learn to listen to what the patient is talking about, and stop assuming, not to discriminate against those who have limited insurance. Learn to understand the patient. I mean, Lauren, do you have any thoughts about that or comments?
Yeah, well, I think, and I've worked with Elle-Marie in the past too. Hi. And I think, you know, her comment is, you know, touching on a few things. I mean, I think ultimately what you don't want to do is use someone's, you know, race or any demographic to make assumptions about who they are. And I think her point there about stopping to listen is critical. You know, one finding that we have in communication research, and not at Karmanos, and not even in oncology, but kind of across care settings, is how quickly physicians and other providers will interrupt a patient as they're expressing their concerns, and how that will often, you know, stymie their ability to convey all that's going on with them, you know, whether it's physical or psychological or otherwise. So I think that's, you know, a really good, you know, a good point, because I think, like everyone, right, we're under a time crunch. And physicians, just like everybody else, are trying to get, you know, as much done as they can during the day. And I think, you know, often that may result in patients not being able to express themselves fully. And other research shows too, that in fact, when you do give patients time to express themselves and to listen, it doesn't necessarily make the treatment visit longer. In fact, it can make it more productive. You know, a basic kind of part of patient-centered skills training is that you give patients the opportunity to kind of get out all their concerns. So that way you're not having like a door handle question as you're about to leave the exam room. The patient then says, hey, no, I've got at least one other thing to talk about. And then that can extend it, you know, ineffectively. So I think, you know, the point there is a really good one.
And Leslie, I'm really sorry if I interrupted you. I certainly didn't mean to stop your feelings. And actually, as you can see in the chat room, everybody was so impressed by what you had to say. I want to direct a question. So think about your comments to this comment, Leslie, but I want to direct a quick question, Natalie. Natalie, there was a question to you about resources. And I think you could just answer them in the chat about what epidemiology books you found inspiring. But a question I was struck with is that you said you weren't aware of these kind of issues until you were, I forgot what you said. I think you said 21 or 22 until you went to university. And so it seems like it's a failure on the educational system, our educational system in this country. You know, if we're really not educating students in all kinds of different groups about what's happening, you know, across the country, what do you think should have or could have been done differently? Or maybe it's me as sort of the age of who your parents are, or how are we failing you? And what could be done differently when you get to be the educator?
Yeah, I mean, I definitely, I don't want to, call out my school or anything, because it's not that it's, their fault. I do think in regards to how we educate even just young kids on, historical issues and civil rights issues, I think there's kind of a focus to just say that, oh, we passed this bill and everything's all good now, when that's really not the case. And I think that the idea of, systemic racism and structural racism wasn't really brought to my attention until, in 2020, obviously a crazy year, but the issues regarding, just civil rights issues with, George Floyd and Breonna Taylor, and the issue of why Black people are disproportionately affected by not only, health issues, but also just financial issues and how these issues have occurred. I think there might be some sort of being afraid to tell students that things aren't all good. And I think that there should be a focus on saying we've come so far and this is awesome, but there's issues that still need to be addressed. And I mean, just focusing on, mentioning that there are still some issues. Even obviously you're not going to talk about cancer disparities in high school biology or anything like that. But I think just in history classes, saying that there are still issues among various populations, and talking about current events maybe more in school might be an option.
Okay, no, that's really helpful. That's really helpful. So Leslie, getting back to you, you are the type of participant that we want. You're educated, you're motivated, you're concerned, you care about your family. It seems like you still have a little hesitation. There's hesitation about samples, maybe a hesitation, and I sort of see our panel, we're looking at our pictures, and of the panel, including myself, and then maybe including the organizers, most of us are white. I think most of the oncologists in the state of Michigan are white. What kind of barriers do you think your friends in your community have in terms of cancer research, in terms of participating in the type of research that Dr. Hamel is doing, and how can we overcome that? What do we need to do to be more open to people to participate?
Here's what I think in the African American communities, not so much in my community, because I think of with my educational background and my economical status and my group of influence, but other brothers and sisters who are not where I am, the cost, like you said, the location and getting to and fro the treatment, having to go at it alone, having improper insurance in the finances to do those co-pays, just taking from some of my family members, having to go 2 and 3 counties over to get treatment. It's a hardship. It is because they don't have the money, they don't have the transportation. And by the time their illness is discovered, it's already at a stage 4. So we have to help them do the screening and medical exams prior to telling them that they have the cancer diagnosis at a stage 4. We have to be able to help them communicate one-on-one with those doctors who are waiting on them. Like my team and I went in with questions and tag teaming. Many of them just take whatever the doctor says and walk out the door, and they don't do the follow-up, or they don't know what questions to ask.
Right. And I think some of what you're alluding to is maybe some of the topic of research that Dr. Hamel is doing, and listening to all the your research and concerns about financial toxicity, which is probably what our patients are thinking about the most. But I wonder, even myself, I walk in that room, I think about it. I think about who my patient is, and if they're going to buy into what I'm recommending, if it's going to be appropriate for them. And a lot of that is whether they have the time and they have the resources. And what is your ideal, Lauren, in terms of dealing with financial toxicity for somebody like me? Something that I would be.
in my tribe world where everything works out as I plan. Yeah, I think, well, here's the thing that clinicians are up against, and somebody put this to me, it wasn't my saying, but that, cancer care doesn't have a menu. Like you go to a restaurant and you know how much you're going to pay for what you're ordering because the list is right in front of you. And it's not really fair for clinicians either. So I think ideally it would be a lot easier and fairer if everyone knew what things would cost off the bat. Now, of course, that we're talking about like precise prices, but also, what I've observed is that clinicians are in better positions to discuss these things than some think, especially regarding like life issues. So how much time away from work, or if they need to have support to drive them to and from treatment, or if they need extra help with kids or other family members, and having an appreciation. And I think that comes with our more seasoned clinicians who have seen a variety of patients go through treatment and some of the things that they can expect. So I focus on financial issues because I feel like you have to kind of plant your flag somewhere kind of precise, but there's also kind of like a broader lifestyle conversation to be had in there too. So I don't think we have all of the pieces that we need, certainly, but I think having understanding from the clinician side of what kind of information to provide, but then like, Elle-Marie mentioned, listening and asking patients like what it is that they're worried about or what things they might encounter, which I'm not saying is easy, but I think, that's, kind of the takeaway, right? Is what's their perspective? Are they worried? Are they concerned? Or what are they worried and concerned about? And especially when you're talking about something that could lead to someone, I think Ms. Wilson, gave such an incredible, summary of her experiences and her journey when you're dealing with something that might, be terminal, and, appreciating that obviously is a concern, but that patients might be thinking about other things too.
Dr. Simon, if I could piggyback on something Lauren has said. When she talked about having a price structure, we can have all of the price structure you want if they can't afford it. The other thing is we don't need to bog patients down with paperwork. And even completing that paperwork, it takes 6 months to get a reply or for some support. You have not helped that patient alleviate any stress that he or she is enduring. You probably have caused more.
I'm sorry, cause more distress by
giving them paperwork, giving them a mountain of paperwork to complete just to get the financial assistance, just to get the assistant, to get a ride, or to be treated. That's what I'm saying. That's what I mean. And then it takes so long to answer the completed paperwork that you've submitted.
Yeah, no, I appreciate that. And all the administrative stuff is really, and especially difficult for people that are coming in with a medical condition, let alone for us, the others. There is part of our job, and we may complain, but we just need to do it. I was just wondering in terms of this price structure, and I think when I think about it, when I have a new patient coming in, I think about, well, what's the best treatment that's for that particular patient in terms of what they could tolerate and what their body will tolerate in terms of other medical conditions. Also, what's going to be the most likely to realize a cancer-free survival. I think what we need to do for our trainees is to help them understand that the finances is a real part of that. That's practical. We could say our grandiose statements and recommendations, and then we leave the room and then leave somebody to pick up. So there's a comment, I multiple myeloma, and I've dealt with multiple doctors and other medical professions too, labs, information about financial assistance, with assistance help complete the paperwork, peer volunteers that new patients can be in contact with. Yeah, so having peer volunteers, and probably peer volunteers like Mrs. Wilson, Leslie Wilson, it is always helpful. We have a few more minutes. Are there, let me see, I know there was something, okay, the question answer is not there. I know that our co-first author, Sreejata, had a comment, and I think Leslie answered that. Natalie, what kind of disparities work would you like to be doing when you graduate from your PhD? What do you think would be an ideal setting or an ideal question? I know that's a big question.
Like if I was to conduct my own research?
Yeah.
Well, right now I'm interested in the molecular subtypes of cancer and how they differ among African Americans versus non-Hispanic whites. I think that molecular subtypes or just the idea of molecular subtypes and the idea of like precision medicine is a really good direction. I feel like that the idea of precision medicine and making your treatment really efficacious to the patient, because obviously, as I can't remember who stated, I mean, not grouping people, like everybody is different. Everybody's cancer is a little bit different, making sure that your treatments are as effective as they can be for you. So personalized medicine would be really interesting. I'm not really sure what direction I'm going to go in yet. If I, stay in academia, if I want to go into government or industry, I mean, I'm definitely open to everything. Government's really calling my name right now, but I have to kind of figure out how to get there.
Great, and actually, I know that Jen is sorry that she got pulled off the conference. I want to do a shout out to the Detroit Research on Cancer Survivorship Infrastructure Grant. This is really a major achievement on the part of Jen and Schwartz, both the PIs and the rest of the investigators on the ROC study, and a really wonderful opportunity to look at questions of survivorship. And we have clinical data, we have socioeconomic data, we have specimens, genetics information, and believe it or not, I'm involved in a study of prostate cancer with Dr. Heath and a second-year medical student looking at genetics of prostate cancer, which is very interesting. Lauren, maybe in 30 seconds, or actually I could say 2 minutes, we pretend we're on NPR, comment on the direction of research in disparities for Karmanos. Where do you see the future taking us?
Yeah, I think, and it's summarized really nicely in the paper too. I think Hayley, Dr. Thompson provides, some great guide posts, I guess. What I'd like to see is, we do a really great job of testing interventions, and we've shown many of them to be effective for various parts of patient communication and patient care. I think now it's on us to start either getting better at implementation science or working with true implementation scientists so we can sort of scale up our interventions, and then they can have a greater impact on other patient populations and not just the ones that we're lucky enough to accrue into our studies. I think most of our work happens in Midtown, but we're attached to a network now too. And so I think we've got an infrastructure in place, maybe not ideal for behavioral science implementation right now, but I think there's a way to get there. And I think we have a lot of the science, I don't want to say figured out, but a lot done. And I know, so Dr. Egley is leading an implementation project right now for one of her previous interventions proven to be effective in the Detroit population. So she's testing it across the state. And I think 5 or 6 of the community sites kind of doing just that. Like, let's test it. Let's get some more effectiveness data. And I think, what her plan is then to just to let it go, like implement it and let, the clinic staff use it like they would any other tool.
Okay, that was great and perfect. And we, we'll let Danny get on in just a minute to make some concluding statements. I really appreciate all of the panel members and their comments and thoughts. This is recorded and anybody could listen to it at any time, anybody even not on this call to get in. And you can, as attendees today, and I know, I think for most of the panelists, some of the panelists is their first book club, you could listen to our discussion of the other books that we've read because they really are eye-opening. And we read Medical Apartheid as the first book for a reason, because that was really the encyclopedia. And it was really the statement of the problem of disparities. And it goes back to the beginning settlement in this country before, white people started messing things up, with the Native Americans and afterwards. So Danny, why don't you close us out? And thank you, everyone.
Thank you, Dr. Simon. Thank you so much to our panelists for such a great discussion. Every quarter we have such a great panel, and this one also was really, really great. I want to give a few reminders as we end up. Yeah, that's it. Yeah, June 16th, we are going to get together and read Unwell Woman, Misdiagnosis and Myth in a Man-Made World. This will be, the registration for that book club will be open tomorrow, and I will be sending out an email to everyone on the email list. And if you've attended today, you're on the list. To register for this event, a recording of this recording that we are now in will be also available on our website, karmanos.org/book club, starting tomorrow. And then we will be having a survey come out to you in pretty much immediately after this session. And it also has things about this session, but also what books you want to cover. That's how we started doing Unwell Woman for next time, is because of the suggestions from the previous. So I gather them up, and then later I'll send out a sort of a poll, and then we will pick our next books from there. So then feedback is great. Thanks for everyone for sticking with us. We had people joining from all over the country, so stuff happens sometimes. So I appreciate it, everyone sticking around. And that's it. So have a great night, everyone. Thank you all for coming, and we'll see you June 16th.
Thank you.
Thank you, Danny.
Thank you.
Bye.